Hello everyone. In this video, we are going to discuss about neurocutaneous syndromes. They are syndromes which involve the CNS and skin. They are usually hereditary, but not always. There are some exceptions. So we need to understand the basic pathology or why they happen. They happen due to a defect in the differentiation of primitive ectoderm. By primitive ectoderm derivatives, we mean the CNS, the eyeball, the retina, and the skin. So, with this basis, we have to go back to know what are the common disorders. The common disorders are NF1, NF2, tuberous sclerosis, then we have Sturge-Weber syndrome, then the von Hippel-Lindau disease, then we have the Face syndrome, then there is something called as ataxia telangiectasia, then the lesser common known syndromes for CNS like the linear nevus syndrome and hypomelanosis of Ito. Hypomelanosis of Ito. Then we have something called as incontinentia pigmenti. So all these are the common disorders, and we are going to discuss some of these. The most common of this is going to be the NF1. So that is a very important thing. So NF1 or peripheral neurofibromatosis. So you need to have two or more of the following seven criteria to be met to name a patient to have NF1 or peripheral neurofibromatosis. So don't worry, we'll make it simple. So skin lesions, there are two lesions. One is called as CAMS. CAMS is nothing but the K-foulate macules. So 6 or more K-foulate macules. And the second thing is axillary or inguinal frickling. So these are the skin lesions. Then coming to the eye. So ocular lesions, this again there are two. So the first thing is going to be two or more Lish nodules. Two or more Lish nodules. And the second thing, the fourth criteria is going to be the optic pathway gliomas. So these are the ocular findings. Then we have neurofibromas. Neurofibromas, since it is peripheral neurofibromatosis, it is going to be either a cutaneous neurofibroma or a plexiform neurofibroma. Two or more cutaneous neurofibromas or one plexiform neurofibroma is a diagnostic feature. Then we have osseous lesions like the sphenoid wing dysplasia or long bone deformities. So all these are the osseous deformities. And then finally we have one of the most important things, which is the first degree relative. So this is very easy to remember, all the seven criteria. So if you can segregate them into the systems which they get involved, we can identify it very easily. So the next thing we have to know is the gene involved is the chromosome 17q, and the protein is the neurofibromin, and this is involved in regulating the RAS activity. The RAS oncogene activity regulation is the function of the neurofibromin. Then coming to NF2 or central neurofibromatosis, the chromosome number is 22q and the protein is merlin or schwannomin. So this is very important. And it is also called as central neurofibromatosis, meaning the neurofibromas are going to be central. So here we get bilateral vestibular schwannomas, which is the diagnostic criteria, or if it is not a bilateral vestibular schwannoma, it has to be a first degree relative with a tumor and unilateral vestibular schwannoma with two of the following lesions. The lesions can be meningiomas, schwannomas, or ependymomas, or even gliomas and posterior subscapular cataract. So all these are the findings which are commonly associated with NF2 or central neurofibromatosis. So this is the diagnostic criteria. So be very clear with these two, and now I'm going to come to the lesser variants of the NF1 and NF2. Schwannomatosis is multiple schwannomas without a bilateral vestibular schwannoma. In the absence of a bilateral vestibular schwannoma, multiple schwannomas is called as schwannomatosis. Then we have something called as Legius syndrome. Legius syndrome meaning it is a milder variant of NF1. So milder variant of NF1, so it is going to have multiple CAMs. This happens due to mutations in SPRED1 gene. So multiple CAMs, that is cephaloid macules, macrocephaly, and with or without skin fold freckling. So this is the characteristic feature of Legius syndrome, a mild variant of NF1. So then we need to know about tuberous sclerosis. Tuberous sclerosis, first thing to remember, it is a multi-system disorder. So it is a multi-system disorder, meaning a lot of systems are going to involve. So the genes across TSC1 and TSC2, 9q34, 16p13. TSC1 will be the protein produces hamartin, and TSC2 the protein produces tuberin. So any defect here is going to produce tuberous sclerosis. So since it is a multi-system disorder, the following systems are involved, like heart, kidney, lungs, eye, bone, and eventually the brain, which is what is more important. So we'll see the other disorders. One is the rhabdomyoma of the heart, or angiomyolipoma of kidneys, and pulmonary lymphangioliomyomatosis. Lymphangioliomyomatosis. Then ocular lesions like retinal patches. Now coming to the brain. We are going to have three important things. One is going to be the cortical tubers or ependymal nodules, and the tumor that is associated with here is going to be SEGA, subependymal giant cell astrocytoma. It is a grade 1 tumor. So that is very, very, very important to know. Then coming to Sturge-Weber syndrome. Sturge-Weber syndrome is a segmental vascular neurocutaneous disorder. It is a segmental vascular neurocutaneous disorder where you have capillary malformations. Okay, so that is the basic pathology here. You have capillary malformations, and these capillary malformations occur in two places. One, in the face and brain, that is the leptomeninges of the brain, and abnormal blood vessels again in eye. So ocular vessel abnormality. So this can lead on to glaucoma. So coming to what is more commonly known, face, you get port wine stain, right? You get port wine stain, and in the brain, because of the leptomeningeal involvement, we have seizures, hemiparesis, and stroke-like pattern. What is important to know here is it is of sporadic incidence. That is very important to know. So this is the exception which I talked about. So it is not autosomally dominant inherited. It is a sporadic mutation. So that is important about Sturge-Weber syndrome. Von Hippel-Lindau, again, Von Hippel-Lindau is a vascular disease involving many systems. The chromosome is 3p25, which I will discuss in a bit. The organs involved are the cerebellum, spinal cord, retina, and the kidney, pancreas, epididymis. Okay, so all these are the organs involved. So cerebellum and spinal cord, we get hemangioblastomas, kidney, pancreas, epididymis, retinal angiomas. So these are the usual features of Von Hippel-Lindau disease, and it is again autosomally dominant inherited, the chromosome being 3p25. Linear nevus sebaceous syndrome, they have nevus, so there is going to be a large facial nevus. So along with the large facial nevus, there is going to be some neurodevelopmental abnormalities in the form of hemimegalencephaly and enlargement of the lateral ventricles. So these are the features that you have to know about linear nevus sebaceous syndrome. Large facial nevus, hemimegalencephaly, and enlargement of lateral ventricles. So finally we come to the face syndrome. Face syndrome is is an acronym for, and I'm spelling it out as PHACE. P for posterior fossa abnormalities, H for hemangiomas, A for arterial anomalies, C for coarctation of aorta, and E for eye abnormalities. Posterior fossa malformation, hemangiomas, arterial anomalies, and coarctation of aorta and eye abnormalities. So in posterior fossa malformation, what we get is Dandy-Walker malformation, or a milder variant in the form of hypoplasia of cerebellum or vermis, or even the corpus callosum and the septum pellucidum. So this will complete our discussion on the neurocutaneous malformations. If you have any doubts, please post me. Thank you. Bye bye.